Hello. Erectile dysfunction means the inability to achieve or maintain an erection during sexual intercourse. It can occur in a person in their 20s, it can also be seen in a person in their 70s. What is the most common condition we see in patients with erectile dysfunction? These patients generally have difficulty expressing themselves, they have difficulty expressing their complaints, they feel embarrassed, and this begins to reflect on their partners, work, and social relationships. Especially in the young age group, if there is an erection problem, it affects the personality of the patient and can make the patient depressed. How do we evaluate the patients who come here? We ask some questions, such as what are the expectations of the patients about erection, how long has it been since it occurred, how many times has the patient had intercourse in the last 6 months or a year, and how satisfied is he in those intercourses. We evaluate many particulars of the patient. Foremost among these particulars are the meticulous analysis of the patient's blood tests, which provide a comprehensive snapshot of their physiological state. Equally significant is the investigation into the expectations harbored by the patient's partner, recognizing the profound impact that relational dynamics can exert on an individual's health outcomes. The patient's lifestyle emerges as a critical cornerstone in this evaluative endeavor. Physical appearance and activity levels further color the patient's lifestyle canvas. Weight management, characterized by being overweight or underweight, can precipitate a cascade of healthy sexual life. Simply put, the patient's eating habits, smoking and alcohol habits, being fat or thin, and being active or sedentary affect his lifestyle. A stressful lifestyle and economic status affect the sexual function of the patient. However, what are the patient's expectations from sexual intercourse? The expectations of people of all ages from sexuality change. Their expectations can also change when they are with their partners. There are two patient profiles. When you ask someone how long they haven't had sexual intercourse, he mentions that he hasn't had sex for 6 months, but when you ask another patient, he says that he only had this problem in one intercourse and that he got upset and that's why he came to me. The expectations of the patients are very different from each other, and this affects the treatment stages. However, the patient's medical history is also very important. Tension, cholesterol, blood pressure, diabetes, hormone levels, previous surgery. Does the patient have reasons that can be corrected? For example, if the patient is on antidepressant treatment, or if he uses a hypertension drug that can cause erectile dysfunction, you can see that the patient gets better when these are corrected. At the heart of this intricate web of factors that converge to shape an individual's sexual well-being, none hold a more pivotal role than the patient's psychological state. The profound interplay between mental health and sexual vitality is unmistakable. Indeed, it becomes apparent that a person enveloped in a heavy shroud of depression grapples not only with the weight of emotional burden but also the potential erosion of their sexual quality. It stands to reason that an individual entangled in the clutches of a dire economic situation might struggle to find the headspace and energy to engage fully in the realm of sexual expression. Likewise, the dynamic between partners takes on a central role in this narrative. A partnership marred by conflict, resentment, or simply a lack of emotional connection can become a crucible for sexual challenges. If these are present, we can reveal that these are the reason for the sexual problems of the patient. When the patient comes, if there are reasons that we can correct, we correct them, we organize his life, nutrition, and movement. We provide permanent changes in living standards. We tell him to stop smoking and drinking alcohol, having a Mediterranean diet, with low carbohydrate, to have an active life, making sport a part of his life. It is necessary to ensure that the patient at least maintains the erection power and reserve. This is also very important. If the patient continues his old lifestyle, perhaps he is not likely to benefit from them in the future. People who do not experience impotence cannot know this. The person who does not experience this thinks that he will have the relationship in the same way throughout his life. When this situation happens to the patient, then he comes to us as if he has hit a wall. It was very good until now, there was no problem, this was the only thing I enjoyed, but what do I do now? Life has no meaning for me, he says. We can use methods that we can treat him with and increase sexual power, but as long as the patient doesn't correct his lifestyle, he will not benefit from them in the future. He will get into more trouble, so the living condition is very important. When we look at the group of patients who have reached the age of 70 and still do not have erection problems, we see that they are very healthy, vigorous, active, and have a Mediterranean type of diet. I see this as a comparison between those who live a village life and those who live a tradesman life. I see the tradesmen as a group of people who are motionless, potbelly, motionless, 1,000 foxes on their heads. And very much of stress. Obviously, he'll have problems under stress. I look at the other patient group. The patient says that he has sexual intercourse twice a week at the age of 65. When I ask him what he does, he says that he collects olives and prunes trees. No stress, no long working hours, and no problems. These are environmental factors in general. However, we can eliminate erectile dysfunction when we normalize the testosterone level in patients with hormonal problems and low testosterone levels. When vitamin and mineral deficiencies are corrected in patients with vitamin D, zinc, etc., the problems disappear. Currently, phosphodiesterase 5 inhibitors, namely Cialis or Viagra, are being used very frequently in patients, and they get a very serious response. Apart from that, if the patient says that he does not want to use chemicals, he can also use substances such as ginseng, tribulus, L-arginine, and L-citrulline. However, what can be done in the next step? Injection treatment with a needle into the penis, stem cell therapy, PRP, and ESWT can be done. If there is no response from them, penile prosthesis can be performed. So there are many types of treatments that we can use as a weapon, and the patient responds to most of them. However, we do not know what response we will get from the treatment until we treat the patient. The patient uses the treatment, and comes back after a certain amount of time. If he is satisfied, we continue the treatment. If he is not satisfied, we can treat him with another treatment. In summation, let us not underestimate the profound significance of lifestyle. Thank you very much for listening. If you have questions, you can write in the comments section, or you can reach me on my website.